Hello, and welcome to the process of correction. My name is Jason Angelette, and today we'll be covering corrective exercise techniques modeled by the National Academy of Sports Medicine. Our client today is Kayana, a 21-year-old female student at Kaiser University in Orlando. She's in overall good health and participates in physical activity on a regular basis. Kayana does have chronic bursitis in her right shoulder with mild popping during rotation. Today we'll be using specific assessments tailored for Kayana to point out key muscle imbalancement to start her corrective training. So let's get started. Our first assessment is a static posture. The client is to stand in a normal yet comfortable position of their liking. From both the anterior and lateral views, we can see certain deficiencies depicted by the red arrows. Immediately, we notice the chronic problems of her right shoulder to stand out as it rounds forward and elevates. The assessment also shows other deficiencies in her head, knees, and feet, which we'll get into a little later. Our second assessment is the overhead squat, one of the most challenging, dynamic, multi-jointed movements to complete. From the anterior view, we can assess the feet and knees of the client. During the movement, she shows some imbalances on her left foot and knee, which cause them to rotate and point outward. We continue the overhead squat assessment by viewing the movement from a lateral perspective. This lateral view allows us to focus on the lumbar region of the back and the client's arms during the movement. As depicted, she shows a slight lumbar arch and both arms leaning forward past her head when they should be parallel. Lastly, we look at the overhead squat from a posterior view. The posterior view allows us to focus again on the client's feet as before in the anterior view, and also the lumbopelvic help complex, or LPHC for short. We can see that both of her heels rise while in the movement, and she has a slight weight shift to the left once in a fully squatted position, which depicts a weakness in the LPHC. The next assessment will be the single leg squat. It is designed to show movement impairments during transition with just one side of the hip joint for assistance. The client will perform this assessment once on each side. The focus areas of this assessment are the foot, ankle, knee, and LPHC. As we can see, the LPHC on the left side drops, which shows weakness in that area, much like in the earlier assessment. Our next assessment is the standing overhead dumbbell press, which is meant to imitate everyday pressing activities. We will look at this assessment from both anterior and lateral views. The primary area of concern during this assessment is the shoulder and its range of motion. As we can see yet again, the client's right shoulder shows deficiencies as it elevates through the movement more than the opposing side. Much like in the overhead squat assessment, her arms near the forward, where they should be in line with the rest of her body. A quick and easy assessment to judge the client's knee flexion and hip extension is the Thomas test. As we can see with just a quick glance, the client shows a tight left rectus femoris and a tight iliopsoas of the right hip. The last movement we will perform is the dynamic postural assessment, better known as the gait assessment. The client just simply walks on a treadmill at a comfortable pace with 0 degrees of incline. From the posterior view, we focus on the feet and LPHC. As we can see, much like in the static posture assessment, her left foot turns outward with a slight valgus in both knees. She is now also showing hip hikes on the left hip, which clearly indicates muscle imbalances of the LPHC. From the lateral view, not much has changed from the static posture assessment, as we can still see both shoulders rounding forward, along with her head tilting down and a slight lumbar arch in her back, like in earlier assessments. So what does this all mean for our client? Based off the results from Kayana's assessments, we can now use this information to specifically pinpoint her muscle imbalances. Here we can see these muscles broken into two separate lists of overactive and underactive muscles. which would be the contributing factors for her deficiencies in her dynamic movements. Going forward, we will now use the National Academy of Sports Medicine's Corrective Exercise Continuum to correct these muscle imbalances. The first stage in the corrective exercise continuum is the use of inhibitory techniques such as self-myofascial release. This technique is used to release tension or decrease activity of those overactive muscles in the body. This allows those underactive muscles to work synergistically throughout the dynamic movements. Self-myofascial release can be done just by using a basic foam roller and placing those muscles deemed overactive on top of the roller. This can be done in upwards of 90 seconds per muscle with minimum pain thresholds. As the client becomes accustomed to the tension, or as the tension in the overactive muscles minimize over time with multiple repetitions, progression can be done to add pressure to these targeted muscles along with the lowering duration of each hold. The second stage in the corrective exercise continuum is lengthening. I have chosen to use the static stretching technique to accomplish the goals required in this stage. This form of stretching allows for relaxation and elongation of muscles. These stretches are held for upwards of 30 seconds at the first point of tension in the muscle. This type of stretching decreases muscle spindle activity and motor neuron excitability. Static stretching will be used in this purpose for lengthening those muscles listed as overactive, and yet again to allow those underactive a chance to assist in dynamic movements. The third stage in the corrective exercise continuum is activation. I have chosen to use the technique of isolated strengthening to complete this stage. The exercises used in this technique isolate particular muscles to increase force production through concentric and eccentric muscle actions. These exercises are applied to potentially underactive muscles that were listed before. The main focus in isolated strengthening is intermuscular coordination, which allows optimal motor unit recruitment and synchronization inside the muscle. This allows those underactive muscles to activate prior to performing integrated exercises, also known as dynamic multi-jointed exercise. The exercises in isolated strengthening should be performed at a frequency of 3 to 5 days per week and achieve 10 to 15 repetitions with at least 1 to 2 sets of completion. Each repetition should consist of a 2-second isometric hold at end range and a 4-second eccentric phase to finish out the repetition. The eccentric phase is held for a longer duration because it has been deemed more effective at increasing total strength and muscle mass. The fourth and final stage of the corrective exercise continuum is integration. This stage now takes the muscles that were overactive, which went through inhibition and lengthening techniques, and now combines those underactive muscles that went through isolated strengthening to perform integrated dynamic movements efficiently. The focus of integration is intermuscular coordination, which differs from intramuscular in the sense of now all the muscles in the neuromuscular system work together with proper activation and timing to complete movements. This stage greatly focuses on limiting deficiencies such as synergistic dominance and alter-reciprocal inhibition. The exercises in this stage should be done at a frequency of 3 to 5 days per week with 10 to 15 repetitions and 1 to 3 sets of each exercise. These exercises should be performed with slow and controlled movement throughout both concentric and eccentric phases. This now concludes the process of correction, and remember, stay fit, stay healthy, stay corrected.